progression of steps. We had a very, very interesting case of a woman who just simply stopped talking, ruled out catatonia, that was called in about this time, not only about this time of day, but this time of year, several years ago. And after a discussion about a tale of possession, I think it was paranormal activity, we went to see the patient after lunch. And it was one of the most memorable cases that I was ever part of. That's a teaser, because I'm not going to give you any more information about that case right now. What I will tell you is that that same week, we had another case called in. Reason for consultation, do we need an exorcist? That was the reason for consultation. I did not see that patient, that was the other team that covered that patient. But I will tell you, because of course, when the attendant came back into the suite, after providing the initial consultation, I was the first person to ask, what happened? And what he told me was that they called the Archdiocese of Metuchen. And the first question that the person asked them, I believe it was a priest, it may have been a deacon or a bishop. Does the individual have established mental illness that you believe is active? The attending answered, in my medical opinion, yes and yes. And the Archdiocese said, our stance is right now, we're to do nothing. So in that case, we'll apply it to Rosemary. We have to come together as a group of psychiatrists or future psychiatrists and determine what is going on from our clinical perspective. And that would be consistent here. And you mentioned postpartum psychosis. And I think that's where the differential would start. You heard me mention this morning. Postpartum psychosis takes one of two general forms in the literature. One is consistent with another diagnosis called brief psychotic disorder. So we should probably talk about brief psychotic disorder in general. What is brief psychotic disorder? Brief psychotic disorder is evidence of psychosis that is brief, operationalized by 1 month or less, that is usually due to the onset of an identified stressor, one example of which is childbirth. And when the stressor is identified as the delivery, brief psychotic disorder in that context is just relabeled postpartum psychosis. Trick question, with an emphasis on the word trick. What percentage of brief psychotic disorder evolves to a more advanced stage of psychosis? Zero. Because by definition, it always ends prior to 30 days. There is a condition, on the other hand, that defines psychosis between 30 days, 1 month, and 6 months. What is that definition?
Huge stress or adjustment.
Louder?
Schizophrenic form?
Schizophrenic form disorder. And again, while we can actually talk about prevalence of schizophrenic form disease that progresses to an even more chronic condition called schizophrenia, we can't have the same conversation about the percentage or the likelihood of brief psychotic disorder evolving to schizophrenic form, because by definition it ends by day 30. If your patient presents to you, if that's the way the test is going to be actually, or the case in yet is going to actually be stated. But in real life, a person can present psychotic, let's say without evidence of childbirth or recent delivery. And the question you're going to get from the patient, the parents, the loved ones is, Doc, what's the likelihood that this is going to actually be something that is much longer? That's a little bit of a different question, because what you're being asked is the potential of you're actually catching a more chronic illness. Let's call it schizophrenic form to remain consistent with the timeline early. And at that point, you should focus on symptomology. What part of the patient's presentation might provide a risk factor for developing a more protracted psychotic illness? Let's say schizophrenic form disorder. Prior history of schizophrenia, of course, but outside of the obvious, what's another question you're probably going to want to ask here or focus on in terms of the notes you took during the initial psych eval?
How quickly it came on? Like if it comes on really suddenly, then there's a better chance it would.
Certainly, if it's an identified stressor, that would be more consistent with brief psychotic disorder. The absence of it would be concerning. Yep, absence of an identified stressor would be concerning. Family history, definitely. Prior history, obvious. The other one is negative symptoms. Negative symptoms are not part of the definition of brief psychotic disorder. Negative symptoms are part of the definition of both schizophreniform as well as schizophrenia. So if you see negative symptomology, that should be concerning. That this is not only brief psychotic disorder, and therefore it is likely to progress beyond treatment. All right. Off that tangent, back to our discussion. The other way in which postpartum psychosis may manifest is as an exacerbation of a baseline bipolar disorder. And whether that's been established or whether that is currently occult is a coin flip. It could be either. But it's thought that biopsychosocial factors localized to the delivery result in the exacerbation. We talked about Leslie as a character of Seinfeld's The Baby Shower as potentially having been diagnosed prior to her pregnancy. And we use that as a case, a fictional case, of why she may have come off the mood stabilizers. And we talk about the teratogenic effects of those mood stabilizers, including lithium and anti-epileptic drugs such as valproic acid. But in other cases, the patient may be without a history of bipolar, and the delivery may have unmasked an occult bipolar illness, which of course is going to be different than a brief psychotic disorder because of the progression of symptoms. For Rosemary, anything in her case history, anything in her HPI test psychiatric history that would allow this group to have an understanding of whether we're dealing with scenario A, brief psychotic disorder, versus scenario B, bipolar affective disorder.
Did she have a precipitating event, like not immediately preceding, but her husband raped her?
So she was raped.
Yeah.
And the idea here would be that would absolutely be a stressor that can induce psychosis. From that context, I think as a clinician, our next question has to be, did the paranoia start before that or incident to that? Anybody have any thoughts about that?
I think the paranoia started after, but then she started pointing to things that happened before.
Well, the rape may actually be it then. Because if it's even if she were now to reinterpret things that previously happened through a psychotic perspective, it's still incident to the trauma. All right, so this is where you guys have to watch the movie again. I'm not reassigning the movie. But if you were nerd enough, you would watch the movie again and now pay specific attention to when the symptoms really had its onset. And if it was before the trauma of her husband raping her, then we're dealing with a bipolar illness. But if it's incident to the trauma, then we're probably dealing with that initial scenario of this being a brief psychotic disorder that's further exacerbated by delivery. Of course, we'd also want to know family history. We want to know past psychiatric history as well. Anything else going on here with Rosemary? Here's a third scenario that I did not bring up this morning in the context of Leslie, but now we'll bring up in the context of Rosemary. And that is that this is a form of peripartum depression, severe with psychotic features. That's the third scenario. And the term peripartum, as mentioned this morning, focuses on the discovery that about half of the symptoms, depressive symptoms, occur during pregnancy. So postpartum depression is a misnomer. And that peripartum onset could actually then, I think, explain why we see the paranoia begin during the pregnancy. Now, we need a better timeline here. Because if only the paranoia manifests without depressive symptoms, then this third scenario is off the table. People would, generally speaking, outside of the case of Rosemary, people with major depressive disorder usually progress through, albeit not non-discrete stages, mild, moderate, severe with psychotic features. And if we see any semblance of that with regard to what's happening during their pregnancy, then MDD with psychotic features is definitely in our formulation. However, if we don't see that, then it's likely to lower our differential diagnosis. Other questions or observations about Rosemary?
Sorry, could I ask for a clarification? Going back to the first point that Julia brought on, to set some ground rules, is supernatural or paranormal activity recognized by the scientific community and psychiatry being one of those as a real thing? And I'm going to bring into here the Lore podcast that Walls Could Talk, which talked about that old mental hospital and people reporting what could be either seen as hallucinations or experiences, like even a child holding their hand, so that could be interpreted as either a supernatural activity or like a tactile hallucination. And so I just wanted to ask, I know we talked about it in the context of a movie, but in the context of also like these real events experienced by people in the podcast.
Gotcha. So the answer to start out as an initial cop-out is kind of.
Mm-hmm.
So first and foremost, number one, when dealing with psychosis, and in this case, I want psychosis to represent the psychosis dissociative spectrum, which neurobiologically makes sense. The APA does have a statement on this, and it's really focused more on the dissociative quality. That is, if an individual, for instance, has the most severe form of psychosis / dissociation, which would be an altered personality, which is diagnostic of dissociative identity disorder, formerly known as multiple personalities, then possession by a demon or the devil is something that is consistent with that condition because of it being culturally sanctioned by some cultures. So the answer is yes. Previous to 2013, previous to the DSM-5, we used to discuss paranormal activity, we used to discuss The Exorcist and other movies, films of demonic possession as metaphors of DID, where the altered personality state, that state that takes over the individual's conscious awareness, is the devil, metaphorically. 2013, with the publication of the DSM-5, that metaphor changed. Now it's real. If people are possessed, they are diagnosed with DID in a culturally sanctioned way. And if they pose some kind of danger, or if it is clinically significant that impairs their functioning, we are allowed to say that it is therefore disordered behavior, even if it's in a cultural context. So the answer is yes, for that particular type of psychosis. On the other hand, when it comes to other forms of psychosis, hearing things, seeing things, the answer is still yes / probably, but it is not as straightforward because it is not as in print as it is for DID, which again is a form of psychosis that you think neurobiologically. So in cases in which somebody will tell you that they have a breach of reality testing, not either psychotic, but it looks like it is culturally sanctioned, I think the clinician best practice would be to investigate whether or not there's a culturally sanctioned belief or behavior that would explain the patient's experience. These often go by specific names. They can be found in a lot of textbooks / online resources. But in the absence of those, we're in a gray area. Right? This also differentiates from culturally bound syndromes, which also have diagnostic labels, but are differentiated from culturally sanctioned beliefs by the fact that within their culture, the behavior is still considered to be abnormal. So again, as clinicians and certainly as somebody sitting for shelf exams, we have to get comfortable with this type of terminology and how you would go about reviewing these terms in the context of providing a case formulation or providing a single best answer. So number one, is it behavioral cultural psychosis within the context of a larger disorder, for example, DID? And if so, is that larger example in print in the DSM as addressing this very question? That is, what do I do in terms of diagnosis? The DSM-5 states that you can diagnose DID in this situation. Number two, outside of it actually being in black and white in a chapter of the DSM, then what? The question is, well, do we know that it actually operates in a culture? And if yes, within that culture, is it considered to be sanctioned versus abnormal? Because that algorithm will bring us to develop in terms of culturally sanctioned behaviors and beliefs versus culturally bound syndromes, which are by definition abnormal. And if the answer is no on both accounts, that third step puts us right in a gray area. Because now we're stepping outside the simple categorization of mental illness by the American Psychiatric Association. Not that that isn't real, but it's a little bit beyond the scope of what we're talking about today. What else do you want to talk about with regard to Rosemary's baby?
Would this be considered like a case of gaslighting by the rest of everyone around her, basically?
The answer is yes. We've got to flip this, though, in a clinical perspective. So I don't think there's any argument that it is. But the discussion for, again, a group of psychiatrists is, well, what can we do about it to help our patient? And I think the first step is kind of circling back to the point I tried to make at the very beginning of the talk. And that is, there's a nice middle ground to achieve with regard to this dichotomy of, well, do I look at this as a psychiatrist, or do I appreciate this film through, through the perspective of a quote-unquote normal moviegoer? And this is where we have a very nice bridge with regard to both. And that is the two-hit hypothesis of psychosis, which is really kind of a more narrowed scope of a biopsychosocial perspective of psychosis. The two-hit identifies an initial hit, which is usually a predisposition. And if we're talking about psychosis, it certainly includes a genetic predisposition, followed by a second hit, often referred to as a precipitant. So not only do we appreciate the biopsychosocial perspective, but as clinicians that are trying to formulate human behavior, we also appreciate another perspective, which we want to merge with the biopsychosocial, called the 3 Ps. What predisposes, what precipitates, and what perpetuates. And when we take the first 2 Ps, we create the 2-hit model. You look at that second hit, and that might be the gaslighting, right? There's a big influence there. And certainly, even if we wish to take a step back, again, we have to be careful about when these symptoms are actually being identified. But the gaslighting, depending on how long it's been going on, can actually be predisposing as well. We just kind of picked this case up at the time of pregnancy, or the time she's raped. But that's the idea here. So yes, it's definitely got gaslighting, but we can still fold that in to a psychiatric formulation if we agree to adopt a 2-hit hypothesis, a 2-hit model for human behavior. In this case, the 2-hit model for Rosemary's psychosis. The first hit, what predisposes, biopsychosocially. That second hit, what precipitates the delusion that she's given birth to the spawn of Satan. That is, that second hit would be the precipitant. Okay? So, yes, gaslighting, but that doesn't necessarily mean that we're going to shed the psychiatric perspective. I really think there's a merging of that now. So let's piggyback. Let's actually allow that for us to segue to a second character in this movie. What's going on with Guy? I'm not so sure he escaped psychiatric evaluation.
He has like a bit of narcissistic personality disorder. Like he really all he cares about is himself and his acting career. And even though like he acknowledges his shortcomings a few times to Rosemary, he like really never does anything to change it, and it is like a persistent behavior.
Raise of hands. Who likes Guy? Even before the reveal at the end of this movie. All right, so I'm going to try to make you think in terms of everything up to the big reveal at the end. Did you like him? Raise the hands, yes. Raise the hands, no. You're not allowed to say you're not voting. So the vast majority say no. Can anybody who raised their hand want to share why? How did he make you feel?
I think I just had this, like, observing their interaction, like, she's kind of this, like, thin, waif like out of control. And generally, like, that dynamic where he's kind of, like, calling the shots, and, like, I just had this, like, aversion to, like, their relationship. And, that, like, kind of made me feel like a little Handmaid's Tale, like, whereas, like, she's just, like, this, like, with the birth being, like, I don't know. I just didn't like their relationship, I guess. I don't know where it's at, but.
From that perspective, of what you just said, if you were to watch Bone Tomahawk tonight, you'll blow your mind.
I've never heard of it.
I don't think everybody has. It's like one of the best westerns ever made. I'll leave it at that. I'm not going to go off too much on a tangent with regard to that movie. Okay. How did he make you feel? Make you feel comfortable? Anybody else? I always found one of the more difficult things to discuss with medical students. I mean, it's simpler to debrief them when our patients code. It's simpler to actually do some of the things that nobody would even think to do. But when you ask them about their feelings, boy, man, they're nowhere to be seen. Right? One of those extraordinary things, and right? I mean, you guys, there's a lot of billboards out there about heroes working here, right? So you guys fit the bill, but boy, try to talk about your feelings, and all of a sudden.
He's like the boyfriend who's like too overpowering, and like I feel like that's how I identified to him, and that's kind of seemed like the gender dynamic. So yeah, I had this like very like ugh,
Anybody else?
Like, if I put myself in her shoes, I just felt like very small, because he's like, I'm gonna be famous, like, we can move into this place so I can do this, like, it was all about him. It's like, that's how I felt, and like, I mean, obviously I didn't like him because he did like rape her, and so I just had a horrible feeling about him, like, basically from the beginning.
How did it make you feel?
It just made me feel bad. Like, I felt sad for her that she was in this situation, like, she kind of felt like she was stuck in that situation. And so it made me uncomfortable when Julia said that.
So, there's going to be a point in time where you're going to refer to a text, to a reference, and you're going to look up the actual signs and symptoms, the diagnostic criteria of narcissistic personality disorder, and you're going to make a diagnosis. And I would suggest that if we apply this to Guy, that he likely will meet criteria for the narcissistic personality. He also shows a blatant disregard for and violation of others' rights, so certainly antisocial personality is in discussion as well. He's a rapist. So, we're seeing cluster B traits. Both of these personality disorders are in cluster B, both narcissistic and antisocial. He could definitely have traits of both. That's why they cluster together. The whole reason why they're put in the same cluster. And ultimately, you'll have to decide as a clinician whether you're going to make two additional diagnoses for him. That is, two diagnoses for the same character, which certainly can happen. And this is a new clerkship, so I'll wind up restating this. But when reviewing personality disorders, certainly look at the clusters. The reason why the APA categorizes these illnesses the way they do is because they do share common traits and characteristics. But for purposes of studying, I also found it very helpful to scrap that. So once you do learn it through the clusters, scrap it, and then reorganize these personality disorders into two groups: those that adhere to a cardinal sign, and those that don't. And in both cases, for these two illnesses, antisocial, narcissistic, they do adhere to a cardinal trait. I mentioned the cardinal trait for the antisocial already: blatant disregard for and violation of others' rights. The narcissist is arrogant, believes they are special, and believes that they can only be understood by someone as special as they are. What's your feeling? When are we younger here? Because once you understand the cardinal trait, when you look at the diagnostic criteria, they morph into simple examples of that cardinal trait. Much easier to remember. What are those cardinal traits?
Conduct, putting it that way.
Like,
When I'm thinking about the cardinal traits, I'm thinking more of like just conduct. Oh yeah, sorry.
Which of course will be the next step, to see if he has conduct disorder prior to the age of
Yeah.
15 and make that diagnosis. Okay. The other thing to consider here, and again, we know that there's checklists, and we know that there's each I think require, or either, the narcissist requires 5 criteria, I believe, the antisocial 3. So at some point, you probably go through that checklist. You diagnose the criteria published in the DSM-5. But then there's a countertransference too, which is defined as the emotions that an individual's transference garners in you. So it's very, I think, worthwhile, certainly part of routine general psychiatry training, to pay attention to your countertransference, so you can actually pick up on the buttons that your patient is pushing you. And at times, you self-reflect, how does that make me feel? Because the answers to that may actually support a working diagnosis. The individual's antisocial personality may have one of 2 qualities that result in 2 separate outcomes depending on the clinician's sex. For a guy, there are some women who may come out of a diagnostic interview with him feeling that he's attractive or charismatic. Men, clinicians, usually do not come out of that same exact eval feeling that way. They have more of a negative connotation with regard to how they feel. I dislike him. I don't like him. It makes me angry. Doesn't always happen, and it's not perfect. But when it does happen, please think of the antisocial personality. When 2 opposite sex clinicians come out of the same interview with those types of differing countertransferences. The narcissist doesn't do that.
He made me feel angry, but not for the reason that I was insecure about anything about myself, but because of the way I saw he treated Rosemary.
Okay?
And like how it was able to be perpetuated because she was, like it was mentioned, she didn't have a job, she didn't have a means to like support herself.
Okay. Anybody else? Actually, more just to hear what the women in the room want to have to say. You guys weren't angry after she was raped?
Yeah, I think it brings up a lot. That's kind of what I felt like. Just like, think of like exes who are kind of like that. I don't think it makes me feel angry.
So if this is the case, again, if we're really case formulating this, the discussion would really go towards what was the impetus? Was it his arrogance, or was it his blatant disregard for her safety and rights as a woman? And your answer is probably going to inform whether, and again, I think there's both here, right? But certainly, which one is going to go higher in your differential and therefore provide greater treatment planning for has everything to do with your answer. And I don't think, again, I think the answer may be different if we actually continue to talk about this as we go through this case formulation. That part's probably a little bit beyond the scope, again, of our discussion today. I think I read it all. And the gaslighting, I think, again, is part of this very discussion. Right? And in and of itself does not allow us to kind of sidestep the idea that Rosemary's baby isn't that of mental disorder nonetheless. Any other observations here?
I just had a question. Like, if a patient comes to you with like similar complaints that she does, what, as a psychiatrist or a clinician, could you do to determine whether her story is accurate or if it's being produced by other people, like as it is in this case?
And it's funny because the more extraordinary the story, you'd think there might be some kind of linear relationship or direct relationship with regard to the likelihood of psychosis. But that's not necessarily the case. And what you're proposing, and I know you posed it as a question, there's no easy answer. But I mean, the obvious first step is to talk to people around who are not part of the suspected delusion to see if in fact there's any reality testing to this. Because even under the most extraordinary circumstances, there might be. There was a very infamous case here way back in the early 2000s of an individual who believed his wife was poisoning him. And we thought he was delirious. His mini mental state exam was 19 or 20. He had a history of mental illness. He was being treated for depression and anxiety. And we were consulted for new onset psychosis as evidenced by the paranoid delusion. Long story short, we found out that his wife was poisoning him. He was putting thallium into his food. So it was a very interesting grand rounds provided by the Division of General Internal Medicine. So, I mean, that happens to you once as a consultant. The way that your question gets addressed is that you go through every means possible, even though your first impression may be, that's extraordinary. Any other thoughts here?
I don't know if there's like a particular disorder that I can associate with this, but I feel like that other couple was very clingy. Like they brought in some random girl from the street and they tried to like rehabilitate her, obviously unsuccessfully, and then they also like really attached themselves to this younger couple and were like almost intrusive in their lives on a daily basis.
Yeah, so, you know, it's funny because I think there, even though it probably didn't get nearly as much attention when this movie was produced, now that we're watching this in 2021, human trafficking would certainly be, I think, a topic of discussion here. And, you know, I know they live in this particular apartment, and there's this particular family that they're neighbors with, but how big is this organization? How big is this cult? And how big is this underground? And are they meeting other women? And are other women ending up at other places with the same problem? So, you know, along that, I want to talk about what Guy, this couple was providing Guy to put in Rosemary's food. Because there's some consistency there, even though I don't think there's a single best answer. Because when you think of cults, one of the people that you think about is Charles Manson. And remember, Manson was very charismatic. Again, he was an antisocial personality / psychopath who certainly had his fair share of marriage proposals. So even in prison, he was married. So there are women who are incredibly attracted to him. And that is actually captured in one of the episodes of Dark Tourist that I would absolutely endorse you checking out. Because as you're watching this from an objective perspective, the easy thing to pop in anybody's head is, how can someone be attracted or be attracted to a person like this? But the answer lies in that dynamic of countertransference. He is an antisocial personality, and even though they're not true clinicians, individuals from the opposite sex who interact with him do find him attractive sometimes, to the point where he has multiple marriage proposals after what he did. Right? And the way he kept the family together was through cannabis and low-dose LSD. So I'm wondering what they're putting in Rosemary's food. Because this cult or coven may work similarly. So that's another thing to focus on here too. And if that is the case, and they were trying to gain some form of mind control, suggestibility with regard to this particular character called Rosemary, well, might that substance also have psychoactive properties that would explain the physiological effect of the psychosis? What role did it play? And again, to investigate that further, we would have to see the onset of the psychosis incident to when she was being dosed. Because not only does her husband sexually violate her, but he poisons her as well. In as much as that he doses her drugs that she does not know she's taking. And we'll end on that very positive note. And that is Rosemary's Baby.